everybody. Welcome back to the Your Go-To Doc YouTube channel. I'm Dr. Robert Feldman, neurosurgeon for over 25 years, here to help you learn about neurosurgical issues. Today's video, we're going to be talking about something called lumbar spinal stenosis. If you've been diagnosed with lumbar spinal stenosis, you've probably had imaging, you've probably seen multiple physicians because of symptoms of back and leg pain. And what we're going to go over today is what is lumbar stenosis, why does it happen, what are the symptoms that can result from lumbar stenosis, and then what you can do about it. So some of the things we're going to talk about have been talked about in my other videos, and the reason for that is that the primary endpoint of a lot of these problems comes from the same issue, which is basically wearing out of the shock absorber or disc in your spine. So let's get right to it. Lumbar stenosis, what is it? What does it mean? So lumbar spinal stenosis. Lumbar means low back, spinal means your spine, and stenosis, which sounds kind of terrible, just means pinching or tightening. And if that pinching or tightening occurs around your nerves, it can cause symptoms. And typically those symptoms are pain in the low back, and sometimes buttock and leg pain, numbness and tingling. And the classic description of symptoms that a patient with spinal stenosis in the lumbar spine will give is that they get pain, numbness, and tingling in the back, buttocks, and legs, worse with walking and standing, that will often immediately get better if they sit down or lean forward. And these are the people that are leaning over the shopping carts in the grocery store or walking stooped over, because when they stand up, the spinal canal and the nerve spaces get tighter when you stand up. And if you're already tight in that area because of the problem of spinal stenosis, standing up and leaning backwards or extending is going to make that tightening worse and bring on those symptoms. So why does spinal stenosis occur? Why do things get tight in the lumbar spine around those nerves? Well, the primary generator of the changes that cause that tightening is the shock absorber or disc in between the bones of the spine wearing out. The disc material, which is a collagen type material, starts to get dehydrated. The ligament that wraps around the bones that keeps that disc material in its place starts to bulge out and get looser and more brittle with cracks in it, fissures in it. And then, because the shock absorber is not working well, the joints that support that level in the spine are under more stress, and they start to kind of rub around too much, and there's excess movement in those joints. Now, not only can that cause pain, but it can stimulate the body to make changes to try and decrease that movement. So what are those changes that occur in the body in response to the disc not working well? Well, all of these changes, as I said, are an attempt to decrease movement. So what are they? Well, number one, the bones around that area that's moving too much because the shock absorber is not working well can grow bone spurs. Now remember, bones are living things. They respond to things like pressure and force. So if there's too much rubbing around going on because the shock absorber in between the bones is not working well, the bones will change their shape to try and increase surface area, which in turn is going to decrease movement. So the growth of these bone spurs will decrease movement and happen in response to the fact that things are moving around too much in there. What else can occur when things are moving around too much because the shock absorber is not working well? Well, the ligaments that keep the bones tight together can get thicker in an attempt to make them tighter. So that ligament that attaches from bone to keep it tight and sturdy is going to get thicker and thicker and thicker because there's too much movement going on. That thickening ligament over time can start to crowd out the spaces where the nerves live. Lastly, what can happen is because the ligament that wraps around the bones that keeps the disc material in place starts to get loose, then that disc material can bulge out from that disc space and push into the spinal canal and cause pinching of the nerves. So all of these things happen because the disc is not functioning properly, which in turn causes too much movement, which in turn causes compensation by the body that crowds out the space where those nerves live. Let's take a moment to look at some pictures of what happens when that change occurs. What happens to that space for the nerves when all those changes happen? And most of this we're going to look at on an MRI because you can't really see these changes very well on an X-ray or a CAT scan. So let's look at those MRIs to see the difference between what a normal spinal canal looks like and a spinal canal with spinal stenosis. What we've got here is some MRIs of the lumbar spine. This picture on the left is a side view of the spine, and these pictures on the right are looking down the tube of the spine. So for example, on the left, this is the L4 bone, this square here. This is the L5 bone, this square here. The black stripe in between are the discs, or the disc or shock absorber in between L4 and L5. And these stringy things running down the middle here are the nerves that go down to your legs. And right here, you can see an area of spinal stenosis, or pinching. The disc is bulging out towards the nerves here, and this black area here is the ligament around the facet joints that has gotten bigger over the years in an attempt to decrease movement. So the combination of the ligaments in the back and the disc in the front being abnormally large or swollen is what causes this pinching around the nerves, otherwise known as spinal stenosis. There's a little bit of that going on up here between the L3 and the L4 bones, but not nearly as bad as down here between the L4 and L5 bones. And down here between the L5 and the S1 bone, you've got plenty of room. You could drive a truck through there. Now, if we look at these same pictures from the down the tube view of the spine, we can see here, this circle here with the little dots in it is where the nerves live, or you could consider this the attic underneath the roof of the house, and in this case the roof is upside down. But these nerves are totally free, nothing pinching them. This is what a normal area of the spinal canal looks like, and if you compare that to the area above here, you can see the space for the nerve is squished down into this little triangle. So this is an example of spinal stenosis, and this entire picture here in the upper right-hand corner is a cross-section slice through this picture right between the L4 and L5 bones right here. So this is an example of MRIs of spinal stenosis. Now let's take a look at another picture of spinal stenosis that's even more impressive. So here we've got some more axial or down the tube images of the lumbar spine, and on this image on the left there's not much of a disc bulge, but you can see this hamburger bun looking thing here with the little white stripe in it. That is called the facet joint. There's one on the other side. But more importantly, this thick black stripe is the ligament that keeps these bones together and tight, that has gotten thicker and thicker and thicker over the years, and that has crowded the spinal canal and caused spinal stenosis. So you can see this little triangle area is tighter than a normal-looking spinal canal. And if we look over here on the right, you can actually see an even tighter spinal canal. There is some disc bulging here, and then in addition you have the thickened ligament, and this area for the nerves is even tighter. So these are examples of what it looks like on an MRI with spinal stenosis crowding the nerves, and in the surgery to fix this, you're basically removing half this facet joint, all of this ligament, half this facet joint, and all the bones sticking out here, and you're basically unroofing this entire area here to make this triangle now a circle and not pinched. So that's what lumbar spinal stenosis looks like on an MRI. This is moderately severe and this is severe. So now one final look, we can take a look at some drawings of the spinal canal instead of an MRI, and this makes it pretty clear. Normal spinal canal on the left, facet joint, normal sized ligament, which is this yellow stripe, and then the disc is right here. Compared to the picture on the right, the disc is starting to bulge out. The ligament has gotten very thick because these joints are rubbing around too much, and the ligament's trying to compensate for that by thickening. And again, this happens over many years, and your spinal canal is squished into this tiny little ball of space compared to wide open space for the nerves here. So this is a good diagram example of lumbar spinal stenosis on the right. Let's take a look at some spine models to see what spinal stenosis looks like in the actual human body. So if we take a look at this spine model, this is a side view of your back. The squares are the bones, and the stripes in between them are the discs. Let's turn this model, instead of looking from the side, let's kind of look down the tube. So if we look down the tube, we see this hole here is the spinal canal where the nerves live. Now if the disc, which lives here, starts to bulge towards the nerves, that hole's going to get smaller. If the facet joints, which are the little joints that connect this bone with the bone above it or below it, if they're rubbing around too much because this disc is not working well, then these facet joint capsules will start to get loose, and the ligament that attaches to them that keeps those joints tight are going to get thicker and thicker and thicker to try and keep these stabilized, because again, the disc is not working well. So if the ligament right here, which is that black stripe I showed you on the MRI, gets thicker and thicker, that will sort of crowd into this space also. And you can see how that big circle is now like a little sliver of space, because if my fingers are the ligament and they get bigger, it crowds that area. If the disc is bulging from here towards the nerves, that will crowd the area also. So this space getting tight is what's called spinal stenosis. Now, an analogy I like to use is the roof of the house and an attic. So let's say that's the roof of the house, okay? And in the attic lives the nerves. Now imagine that Pink Panther insulation stuff is disc bulging or ligaments getting thicker, and over time, over the years, as that ligament gets thicker and thicker and thicker, your attic starts to look like this instead of like that. And that is what spinal stenosis does to the space for the nerves. It makes the attic smaller and the nerves that live inside the attic under pressure. Now, when we eventually talk about what you can do about that, we'll talk about what I do with the surgery and this analogy of the attic and the roof. So, let's now talk a little bit about what are the symptoms that you get and why. Why, when the nerves get pinched from spinal stenosis, do you get the symptoms you get? And why is it more commonly worse when you stand and walk? Well, if you look again at this model, these are the holes that the nerves come out of. And when you are leaning forward, those holes get bigger. That's leaning forward. When you lean backward or stand up, those holes get smaller. Downward pressure standing up in the setting of a bad disc, this hole right here is going to get squished when you stand up compared to when you lean forward. When you lean forward, that hole gets bigger. So in the setting of crowding in these areas by the changes of spinal stenosis, bulging discs, thickening ligaments, the act of vertical standing and vertical pressure and the act of leaning backwards are all going to crowd that space and make the nerves unhappy. Leaning forward and sitting down, that makes those spaces bigger. It relieves the pressure. So again, people with spinal stenosis in the lumbar spine, these are the people that are going to be leaning over the shopping carts in the grocery store. These are the people that have to lean over the kitchen sink when they stand up to wash the dishes all day. These are the people that may be leaning over with a cane when they walk, because standing up straight makes their butt cheeks and their legs ache and their back hurt. And that's basically why you get those symptoms running down your legs when you stand and walk that gets better when you sit down or lean forward. So now let's talk a little bit about what are your options for treating spinal stenosis. You've seen your primary care doctor. You tell them your back and your legs hurt when you stand and walk. They tried some conservative therapies. They did some imaging. They sent you to a neurosurgeon or physical therapy. What are all these options? Well, option number one is to put up with it and do nothing. Most people, by the time they're looking at this video or they're going to have an appointment with a neurosurgeon, they've tried that already. But technically, if most of the activities that you do not cause pinching enough of those nerves for you to have enough symptoms that your quality of life is significantly impaired, you may want to do nothing, and that certainly is an option. The second option is basically something called conservative therapy, and that basically means anything but surgery. The list of those things are, and just because I list all of these things doesn't mean I recommend all of them for you in particular. or that all of these will work for you in particular, but they include things like anti-inflammatories, muscle relaxers, pain medication, physical therapy, heat, ice, massage, chiropractor, hanging upside down, traction, wearing a back brace, creams, rubs, patches, steroid pills, steroid shots, and injections in the facet joints. Now, all these things are nice. Some of them work, some of them don't. You could have two people with the exact same problem, and some of those things will work in one person but not the other. But for lumbar spinal stenosis, which again is just crowding of that space for those nerves, none of those things I just mentioned are really going to physically change anything in there. So typically, conservative options are not really a great choice for lumbar spinal stenosis. They just tend not to work. So most people with spinal stenosis that gets to the point where it's interfering with their quality of life enough, they're going to end up talking to a neurosurgeon or a spine surgeon about unpinching that tight spot. So let's jump right to the surgery that's involved in treating lumbar spinal stenosis and unpinching those nerves. The surgery for treating lumbar spinal stenosis is typically something called a lumbar laminectomy, medial facetectomy, and foraminotomy. So let's break that down. What's a lumbar laminectomy? Well, lumbar basically means low back. Laminectomy means to remove the lamina. If we look at this model of the spine that we looked at before, the lamina, if we turn it this way, is the V-shaped or Y-shaped area right here. This is the spinous process, the pointy thing that runs down our backs, but the V part of that is the lamina. So you're basically removing the Y-shaped area here. So that's the laminectomy part. The medial facetectomy this is the facet joint or facet joint, and medial means on the inside. So you're removing this inside section of this facet joint. And foraminotomy means opening up the foramen, which is the hole that the nerves go out of. So laminectomy, remove the roof of the house. Medial facetectomy means removing all that Pink Panther stuff that got thick. And foraminotomy means removing or making bigger the hole that the nerves go out of. So if we go back to that analogy of the roof of the house, basically in the surgery, we're removing the roof and the Pink Panther insulation stuff that's gotten bigger and bigger. So now instead of your roof looking like this, it looks like this with no roof on top. And the nerves are basically sitting in the attic free of pinching. And you can get away with multiple levels of laminectomies. You could remove 1, 2, 3, 4, 5, all 5 of these little pointy things. And if you look closer, this black line is where you would remove the lamina, and you can basically remove all this stuff on the back of the spine to unpinch those nerves. Here's an example of a section of the spine that's had a laminectomy done to it, and here you can see the pointy thing, the spinous process is gone, and the bones have been removed up to this point, and that is now free of any pinching, and all the nerves running in the spinal sac right here are going to be floating in the wind, free of compression. And that surgery, called a lumbar laminectomy, can take an hour to 3 hours depending on how many levels you're doing. But basically, what's involved in that surgery is you are asleep, you get rolled over on your belly on a special table, an incision is made in the middle of the spine, the length of which is based on how many levels you're doing. You go down to the spinous processes, which are those pointy things, scrape away the muscles that are on them and retract those muscles so that you can then see everything. Remove the spinous processes, remove the lamina, remove the ligament that's digging into the nerves, feel around the nerves, make sure there's no disc bulging or pieces of disc pinching the nerves. Take a little probe and feel out the little holes that the nerves go out of, and any spot that feels pinched, you basically make it unpinched. Explore everything, make sure everything feels nice and free, and then sew you back up. Typically, when I do this surgery, there's a lot of oozing from the muscles, so I'll often put a drain laying on top of the spinal canal that will keep any blood from the surgery or after the surgery from pressing on those nerves. the blood can get out of the drain overnight, and then by the next morning all the bleeding stopped, especially since patients are mostly lying on their back, and then you just take the drain out the next morning. So typically my patients will see me in the office a couple of weeks before the surgery. I'll go over the risks and benefits, what to expect before, during, and after. We'll get some blood tests, an EKG. Sometimes they'll need medical clearance from their primary care doctor. They'll show up at the hospital, meet anesthesia, bring them into the OR, put them to sleep, roll them over on their belly, and then do the surgery I just described. They'd wake up in the recovery room. Their back will be a little sore, but not terrible. That little plastic tube coming out of the incision we'll take out the next morning, the drain, and usually I'll keep them overnight in the hospital. The first night they just take it easy. They're allowed out of bed to go to the bathroom, but that's about it. The next day, the nurses will take the drain out. Therapy will walk the patients in the hallways. I'll be in around lunchtime. I'll look at their back. I'll ask them how they're feeling, and hopefully what they'll say is, my back's a little sore from the surgery, but I just did loops and loops around the hallway and I could stand up straight and walk without any buttock or leg pain. And typically these patients will notice the difference immediately. That very next morning when they walk in the halls, they don't get that aching, painful sensation in their back, buttocks, and legs. If everything looks good, I'll let the patient go home. 3 or 4 days stuck in the house not doing much, and that doesn't mean lie in bed all day, but just stay home. They're allowed up and down steps, sit on the porch, watch TV, read a book, take a nap, stare out the window, watch the grass grow. After the first 3 or 4 days of stuck in the house, they're allowed out of the house to go to something light, something easy, something minimally active. The grocery store, visit a friend for an hour, something light like that. After 1 week, the patient can drive, short trips only, the bank, the post office, the grocery store. But for 2 weeks, I basically ask the patient to be a slug. No bending, no twisting, no lifting more than 5 pounds, no housework, yard work, walking the dog, taking the trash out, exercise, sports, home improvement projects, hang gliding, skydiving, lay low for 2 weeks. They'll be back in my office in 2 weeks for a checkup. I'll look at their incision, ask them how they're feeling, and if everything looks good at 2 weeks, I will then let them slowly start adding their activities back little by little, starting with the small stuff, working their way up to the big stuff over the next 4 to 6 weeks. So short answer is by 6 to 8 weeks after the surgery, they can go hang gliding and skydiving again. If everything looks good at that 2-week mark, from my perspective, they're kind of off the hook. They don't have to come back and see me. And then I'll usually send their primary care doctor or their referring doctor a letter and let them know how they're doing. And that's typically what to expect kind of before, during, and after the surgery. Now let's take a little bit of time to talk about the risks of the surgery. What are the risks of lumbar laminectomy, medial facetectomy, and foraminotomy for lumbar spinal stenosis? Well, there are 3 risks for any surgery. It doesn't matter what kind of surgery it is. Could be a heart transplant, could be an ingrown toenail surgery, could be spine surgery. Same 3 risks. Infection, bleeding, problems with anesthesia. All very low risks, but they're in the book, so I have to tell you about them. And that's why before the surgery, we'll get some blood tests, make sure your blood clots properly, make sure your electrolytes are good, make sure your kidneys are functioning properly. We will get sometimes an EKG to see how your heart is doing. We'll sometimes get a chest x-ray to see how your lungs are doing. We will sometimes send you to your primary care doctor or a cardiologist for some kind of medical clearance before the surgery, basically telling us that you're healthy enough to undergo the surgery and withstand the anesthesia. So those 3 risks: infection, bleeding, problems with anesthesia. For infection, you're usually given antibiotics before the surgery, sometimes after. The surgery is done in a sterile environment. Even though we do all those things, there is still a small risk of infection. Typically, those risks of infection are mostly superficial infections, which are easily treated with antibiotics. Risk of bleeding, not too big a deal in this kind of surgery. Mostly the bleeding comes from the muscles around the spine as opposed to the spine itself. And that's why sometimes if there's a big opening around the spine, I'll put a drain in there overnight so that the blood that is expected to occur after surgery doesn't press on the nerves. Risks of anesthesia are things like pneumonias, urinary tract infections, blood clots in the legs that can travel to the lungs, stress on the heart, those types of things, and that's one of the reasons why we can assess your level of risk for anesthesia with the tests that we do beforehand. And those 3 risks are for any type of surgery you're going to do. There are a couple of risks that are special to this surgery because of where it is. So that includes injury to the spine or the nerves, either inside the spinal sac or the nerves that are leaving the spine. Very, very low risk. But again, it's in the book, so we have to tell you about them. And the main issue of minimizing that risk is to be very careful as a surgeon. And for me personally, everybody for that 1 or 2 hours is my father, mother, brother, sister kind of thing. Everyone gets the same treatment every time. So being careful is the #1 rule for avoiding injury to the nerves. But keep in mind that if you've had surgery in the same area before and there's a lot of scar tissue, that can certainly increase that risk. Injury to the nerves could be as minimal as a little bit of numbness after the surgery, or could it be as significant as a permanent weakness in the muscle that's supplied by that nerve. Knock on wood, I've never hurt anybody's nerves before, but that risk is in the book, so again, we have to tell you about it. The second special risk that's special to this kind of surgery because it's spine surgery is something called spinal fluid leak. The covering of the nerves not only keeps in the nerves, it keeps in spinal fluid. If you get a tear in that covering, that fluid can leak out and give you headaches. Typically, if that happens, you see it right away during the surgery. Clear fluid will be leaking out of the membrane where the tear is or the hole is. There are ways to fix that problem. You can sew up that hole, you can patch it, you can glue it. Lots of ways to fix that. Again, very low chance, but it's in the risks, so I have to tell you about it. The risk for that is slightly higher if you've had surgery in that area before because, again, scar tissue can make everything get stuck in there. So trying to decompress the nerves and the spinal sac in the setting of scarring can increase that risk for spinal fluid leak and a tear in the covering of the nerves. The final risk, which is not a risk particularly for the surgery itself, it's just that if you are going to be removing those structures to unpinch those nerves in the lumbar spine, you're taking away some of the structural support of the spine. In most cases, that's not relevant. The patient's lumbar spine will remain very stable. But in patients who are already unstable or loose in one of those areas, by taking away those structures, you can make them even more loose and increase chances of instability and pain from instability. One of the ways to check for that is to make sure you look on the x-rays before the surgery that the bones in the area where you're doing the surgery aren't offset or not in alignment. Or on x-rays where the patient bends forward or bends backward, which are called flexion-extension x-rays, you don't see wiggling. You don't see excessive movement one way or the other when the patient bends forward or backward. If there is instability in the spine, the surgeon may want to consider doing not only just a decompression to unpinch those nerves, but a fusion to keep those bones together and keep them there fused. So that's pretty much the risks of the surgery. Infection, bleeding, and problems with anesthesia, and then injury to the nerves, spinal fluid leak, and progressive instability. So thank you again for watching. This video segment was about lumbar spinal stenosis and the treatment. Please like and subscribe the YouTube channel and keep your eye out for more videos on more topics. Thanks again for watching your Go-To Doc YouTube channel. I'm Dr. Robert Feldman. Stay healthy.